Welcome, ladies and gentlemen. In the following few minutes, please let me introduce my progress in my PhD topic, which is about a translational approach for better awareness of cystic fibrosis-related glucose abnormalities. As well as I'm a PhD student, I'm also a pediatric resident who is involved in the clinical care of patients with cystic fibrosis. Therefore, my vision and my mission is to improve the life quality of these patients by applying up-to-date results in the clinical assessment of cystic fibrosis-related glucose abnormalities. To estimate the significance and assess the global and local prevalence of this cystic fibrosis-related complication, we are conducting a cohort analysis and a meta-analysis in this topic. The life quality of these patients and the life expectancy increased in the past decades thanks to new therapeutic options. Therefore, complications that need time to evolve, such as osteoporosis or cystic fibrosis-related diabetes, has come into light. The diagnosis of diabetes is associated with increased mortality, which could be avoided by early recognition and treatment. By the age of 40, approximately half of the patient has diabetes. But we have to think about diabetes as the end stage of a progressive disease, the abnormal glucose tolerance spectrum, and basic scientific research suggests that prediabetic conditions such as intraterminal glycemia or impaired glucose tolerance precedes this end stage by ages and evolves in the early childhood. Despite that fact, oral glucose tolerance test, which is the gold standard method for diagnosing this glycemia, is only recommended from the age of 10. Therefore, the characteristics and the dynamics of the progression between different glucose tolerance status is still unclear. That's why we wanted to know the exact prevalence of abnormal glucose tolerance in different age groups of cystic fibrosis. We hypothesized that abnormal glucose tolerance is already more prevalent under the age of 10 in patients with cystic fibrosis compared to a healthy population. After the systematic search and selection process, we included 596 articles and studies in our meta-analysis. Due to the vast amount of data, we examined several outcomes regarding the whole spectrum and each of its subtypes. The size of the circle and the number in it represents the included studies in each outcomes. Now I would like to talk about the most important ones signed by the red circles. Firstly, we examined the prevalence of abnormal glucose tolerance in different age groups of cystic fibrosis. As you can see, in every pediatric age group, a third of the patients are affected by abnormal glucose tolerance, which increases significantly, and in the adulthood, half of the patients are affected by abnormal glucose tolerance. Comparing these proportions to general age-matched populations data from the IDF Diabetes Atlas, we can see that abnormal glucose tolerance is 6 times more prevalent in the pediatric and twice more prevalent in the adult cystic fibrosis population. By examining the prevalence of cystic fibrosis-related diabetes, we can see the prevalence is 9% in the pediatric cystic fibrosis population, which increases significantly, and in the adulthood reaches 27%. Furthermore, there is a visible tendency in the increase in the pediatric age subgroups from approximately 0% in the 0 to 5 years of age subgroups to 11% in the 10 to 18 subgroup. Comparing these data, we can see that diabetes is significantly more prevalent, 90 times more prevalent in the cystic fibrosis pediatric population compared to a general age-matched population, and twice more prevalent in the adult population. Last but not least, I would like to show you a diagram which represents the risk to have diabetes as the function of age. As you can see, the red lines, with the gray lines, the 95% confidence intervals. As you can see, the risk to have diabetes increases through life, most rapidly during teenagehood, but as you can see, this increase starts before the age of 10. And this is just the end stage, and pre-diabetic conditions preceded by ages. So as a conclusion, we can say that abnormal glucose tolerance is highly prevalent in cystic fibrosis even under the age of 10. But under the age of 10, only 10% of the abnormal glucose tolerance cases are end-stage diabetic, whereas among teenagers, 1/3, and in the adulthood, half of the patients are diabetic. These patients have already lost the possibility for early intervention and treatment, which could have maintained a better life quality. So therefore, better awareness is needed for screening and treating abnormal glucose tolerance, especially under the age of 10. It's time to reconsider the current guidelines and start OGTT before the age of 10 and start dietary interventions as soon as possible after the diagnosis. And there is unmet need to develop a patient-friendly screening method for toddlers who cannot drink the sugary liquid, which is needed for OGTT. Due to the vast amount of supplementary data, the article draft is finished, but the supplementary edition is not done yet, so we will send our draft to internal review next Monday. But what is the prevalence of abnormal glucose tolerance among Hungarian cystic fibrosis children, and what happens with them after the diagnosis? The Cystic Fibrosis-Related Pancreatic Disorder Registry's aim is to assess the prevalence of abnormal glucose tolerance in our registry patients, especially under the age of 10. Currently, 110 patients are involved in our registry, and we have analyzed the 79 patients' data, the first 79 patients who were able to undergo OGTT, who were previously diagnosed with diabetes. The long-term aim of this prospective registry, by the yearly follow-up visits and yearly reevaluating the data, is to earn knowledge about the characteristics and dynamics of the progression between the different glucose tolerance status. In 2022, we have followed 87 patients and involved 7 new ones. By analyzing the baseline data of the first 79 patients, we can see that abnormal glucose tolerance is 30 or 40% in every pediatric age group, even under the age of 5, even under the age of 7 or 10. In this population, the percentage of diabetes is 9, which increases to teenagers to 30%. Here you can see a table with the 4 glucose tolerance status from normal to cystic fibrosis-related diabetes and the basic characteristics of the patients. As you can see, the more progradiated is the glucose tolerance status, the worse the lung function and the bacterial colonization is by looking at the forced expiratory volume parameters or the chronic Pseudomonas aeruginosa infections. So we can conclude that the results of our cohort analysis harmonize with the results of our meta-analysis, so since both underline that abnormal glucose tolerance is highly prevalent in cystic fibrosis even under the age of 10, where screening is not mandatory according to the current guidelines. But we have to emphasize that this have to change because the uncontrolled glycemic status leads to rapid clinical decline. And thank you for your attention. And as Winston Churchill once said, however beautiful the strategy, you should occasionally look at the results. And Merry Christmas to everyone.
What can you do in children to delay the progression of the carbohydrate metabolism dysfunction?
Thank you for your question. The first intervention that we do is dietary intervention, so native glucose-free diet, which means that rapid absorptive glucose should be avoided, and long absorptive glucose is the energy that we want, the energy source.
My question relates to the problem of, it's genetically coded that your pancreas is going to die away. Can you delay by any intervention the deterioration of the function of the Langerhans islets and the beta cells?
Your question is excellent. So it will die at one point, at a certain point, but we can delay it with the dietary interventions because we avoid insulin breakthrough with the long absorptive glucose diet. While in the fast absorptive glucose diet, there are insulin outbreaks which cause the pancreas to die sooner. So we see that patients who do not take the dietary intervention seriously prograde much faster. For example, a 5-year-old girl showed up last week who now has definitive diabetes, while 5 years ago she had IGT, and we knew that she didn't take the dietary intervention seriously. And we have a 12-year-old boy who takes dietary intervention seriously, and he is still in the IGT status for, I think, 3 years now. So it's perfect, I think.
What is your experience about the follow-up period?
Thank you for your question. Our patients are called back for every 3 months, so there is not a dropout regarding the registry, because we bring yearly physical examination. We do the OGTTs as well, and as I mentioned before, those who take the dietary intervention seriously prograde so those who didn't take the dietary intervention seriously prograde faster than those who take it seriously. This is the first experience with the registry.
My question would be, coming back to Balin's question actually, does a dietitian see them, or do the doctors give the advice regarding the therapy? Do the mom get support regarding how to cook, psychological support with fussy eating children who don't really want to go on a diet?
Thank you for your question. We work in a team, so dietitians see them, and they have the possibility to go there every occasion than they want, and we also give them advices. So also psychologists work with them, so we work as a team, so everybody do the job.
Thank you.
I was just thinking about the same, like patients with cystic fibrosis, they need to plan ahead. So they need to do a lot of everyday practice to decrease the long-term effects. And this would be another one. So it could be a huge burden for especially parents. So do you plan to like, so how would you like to convince them to do another factor? It's just a hypothetical question, meaning like, this should be really, really hard, but really, really good for them in the long term.
Yes, you are right. It's a really hard work to convince them that they need to take the dietary intervention seriously. And these are long talks with the parents and the children to take these dietary interventions and accept it, and we're talking about it every occasion when they appears. And even if we are convinced, for example, the parents, and we have a teenage boy or girl, they do not really take the dietary interventions as seriously. And with the hormonal changes, it gets worse, not just for the psychological side, but for the physical side aspect as well, because the rapid increase and the rapid progression starts there. So I think the teenagers are the most complicated patients in that way.